Sir, it's sharp 5:30, so with all your due permission, can we begin with the session?
I'm ready. You can at any time you tell me, we'll start.
All right, so it's time, sir. So I'm starting with your introduction, then we'll be handing it over to you.
Sure. Thank you.
Good evening, all the viewers. This is Batul from IGCP, and I would like to welcome all the viewers at our platform who have joined our platform for the better exchange of knowledge that is going to be shared by our keynote speaker, doctor, for today's session. He is none other than Dr. S.B Gupta, sir. Sir needs no introduction, but it's my pleasure and honor to introduce him at our platform. Sir is MD in General Medicine, FSCC, Consultant Physician, Cardiologist Care Clinic, Charco, former Head Department of Medicine and Cardiology, Central Railway Headquarters Hospital. With the help of Sir, we'll be taking a close look on today's topic, which is ventricular premature beats, when to treat. Before moving on to today's session, let us have a brief look on what the topic contains. A ventricular premature beat is an extra heartbeat resulting from abnormal electrical activation originating in the ventricles. The lower chambers of the heart before a normal heartbeat would occur. We'll be knowing more about the topic in an elaborative way with wonderful insights with the help of Sir. So now, before any delay, I would like to welcome Sir and would like to hand over the session to him for his talk to begin. Sir, over to you.
Thank you, Batul. Good evening, viewers. I'm happy to share today's topic, which is, I think, very important for all the doctors who are treating patients. When we talk of ventricular premature beats, I think most of the time I have given talks ventricular premature beats when not to treat, because as soon as the doctors or GPs or the physicians, they see ventricular premature beats, they jump on to treat. So, and ventricular premature beats are mostly, it's a benign condition which needs not to be treated. But today I'm talking on a different subjects, that ventricular premature beats, when to treat. So ventricular premature beats is one of the most common form of arrhythmias, and most of the time the ventricular premature beats are asymptomatic, but rarely they may cause palpitation. I think a lot of people, they say they get a feeling of an extra beat, or they feel some dhad in the chest, and that may be the only symptom. But rarely patient may complain of shortness of breath, dizziness, chest pain, and fatigue. Sometimes it may lead to even just a bit of loss of consciousness, which may be called as presyncope, where patient usually does not lose consciousness, but he feels that he's going to become unconscious. Or it may lead to a true unconsciousness, which is syncope, or rarely it can lead to even heart failure. But these are the rare things. Again, I'm telling you that it is mostly it's a benign condition, especially if it is associated with normal hearts. And it may require treatment when symptoms are troubling and incapacitating. PVCs, when associated with structural heart disease, like ischemic heart disease or valvular heart disease or congenital heart disease, it causes an increased risk of sudden cardiac death. And there is an entity which is called as PVCs, premature ventricular contractions, induced cardiomyopathy, which we'll be talking in due course of time. Now, ventricular premature beats in general population, the prevalence is just 1 to 4%. Means in approximately 1 to 4% people will show ventricular premature beats. But if we record the ECG for a longer duration, like when we are doing an Holter monitoring, we may see the ventricular premature beats, the prevalence is 40 to 75%. And longer the duration of recording, the prevalence of ventricular premature beats will go on increasing. And the prevalence also increases as the age advances. It is less than 1% below the age of 11 years, and it's almost 70% or more in subjects above the age of 75 years. Why to treat ventricular premature beats? Because of its incapacitating symptoms. Sometimes I have told you, rarely patient may have an incapacitating symptoms, and the reversal of PVC induced cardiomyopathy, which we'll be talking in due course of time. Now, what is PVC induced cardiomyopathy? PVC induced cardiomyopathy is entity which happens because of when there is the PVC burden is very high. PVC burden is very high, that means, and we are recording the 24-hour CCG, and we see how many beats are there, and out of these beats, how many are premature ventricular contraction. So if PVC burden is very high, it can lead to LV dysfunction, left ventricular dysfunction, systolic dysfunction. That is PVC induced cardiomyopathy. And if we suppress the PVCs, the LV systolic function improves. That's how we say these are PVC-induced cardiomyopathy, because there are conditions like dilated cardiomyopathy or other familial cardiomyopathy, which are already there is a suppression of LV dysfunction. And when the LV function is suppressed, that can also result into the PVCs. So whether the cardiomyopathy is because of PVCs or the cardiomyopathy is resulting in PVCs, the only way to know about whether it's a PVC-induced cardiomyopathy, that when we suppress the PVCs, then if the cardiomyopathy improves, then it may be PVC-induced cardiomyopathy. I have told you that higher the PVC burden has shown to correlate with the extent of LV dysfunction. And one of the studies said that if the PVCs are more than 20,000 per day, then it can lead to inducing cardiomyopathy. The other study says that even if it's more than 10,000 PVCs per day, it can lead to PVC-induced cardiomyopathy. Another study, they do not talk of the absolute figures. They talk of if the PVCs are more than 10% of the total beats per day, then it can lead to PVC-induced cardiomyopathy. Now, PVC, which are originating from the right ventricle, they are more dangerous to induce cardiomyopathy, and significant reduction in LVEF at the PVC burden of more than 10%. While if the PVCs are coming from the left ventricle, the significant reduction in LVEF happens at the PVC burden of more than 20%. Now, if the PVC duration, the duration of the PVC is more than 140 milliseconds, when we are talking of the duration of any beat, one small square is 40 milliseconds. So if the PVC duration is of more than or equal to 140 milliseconds, it is an independent predictor of impaired left ventricular ejection fraction. There are so many theories are there. I will not go into the details of how this PVC-induced cardiomyopathy happens. It may be because of increased oxygen consumption. We know ventricular dysynchrony can happen because of the PVCs, and if there is a burden is very high, it can lead to dysfunction. Then most of the tachycardias like atrial flutter, atrial tachycardias, etc., especially in childhood, can lead to tachycardia-induced cardiomyopathy. Similarly, the PVC burden is very high. That may be one of the factors which may be cause for PVC-induced cardiomyopathy. Then there are alteration in intracellular calcium and hemodynamic impairment, or alteration in heart rate dynamics, and myocardial and peripheral vascular autonomic dysregulation. These are the thought to be the causes for PVC-induced cardiomyopathy. Now, how to evaluate these PVCs? One has to take a careful clinical history and look for whether these PVCs are causing symptoms. What is the effort tolerance of the person, whether is normal effort tolerance or his effort tolerance is NYHA class 1, class 2 or so, and how incapacitating are the symptoms and their relation with PVCs. The relation with PVCs can only be judged when we are doing like Holter monitoring, and patient says that his symptoms are happening at the time of when there is PVC burden is high. So that's how we can correlate the symptoms and the PVCs. Then we have to do a good physical examination to rule out any structural heart disease. And then we have to take a good family history to rule out any familial cardiomyopathy, so that we know that whether the cardiomyopathy is the cause for PVCs or PVCs are causing this PVC-induced cardiomyopathy. Then we investigate these patients. We do a routine ECG, which will tell you about whether the PVCs are unifocal, multifocal, they are coming in couplets, triplets, or there are short runs of ventricular tachycardias, etc. So ECG may show that, or we may do a 24-hour or 48-hour ambulatory ECG monitoring that will also tell about whether the PVCs are coming from which chamber, again, whether they are unifocal, multifocal, or in couplets, triplets, or there is a short runs of VT. Then we can do even event recording. Patient complains of symptoms, then at that time he can do, there is a monitor which records ECG when the symptoms are there. So event recorders are there, or there are, because the Holter is recording the ECG for 24, 48 hours or maximum 72 hours, but there are external loop recorders or internal loop recorders which may record ECG for 7 days, or internal loop recorder can record the ECG even for 1, 2, 3 years also. Then we have to do an echocardiography again to rule out any structural heart disease. We have to look for LV function, or if there is any valvular heart disease or congenital heart disease. So we have to do an echocardiography. Sometimes we may do a stress testing to see whether these VPCs can be suppressed on the stress testing, or on stress testing the VPCs appear. If the VPCs are suppressed on stress testing, likely they are of benign nature. And if they are coming on stress testing, then we have to really further evaluate, because these stress-induced PVCs are again more prognostically bad. Then we may have to do cardiac MRI sometimes, because certain PVCs are related to myocarditis. It may be related to certain myocardial diseases like sarcoidosis, or in India, even tuberculosis of myocardium can lead to PVCs. So sometimes if there is any suspicion, we may have to do cardiac MRI to rule out these sarcoidosis or tuberculosis, etc., etc. And rarely we may have to do even a coronary angiography to rule out any coronary artery disease, which may be the cause for suppressed, depressed LV function, and the cause for PVCs. Then management again depends upon the symptomatology. I have told you, if the symptoms are incapacitating, then we have to treat, depends upon the PVC burden. If the PVC burden is very high, then we have to suppress the PVCs. Underlying structural heart disease is there, and they are more prognostically they are bad. Or if there is strong suspicion of PVC-induced cardiomyopathy, then again we have to treat these PVCs. So these are the areas where we have to treat the PVCs. One, I have told you the symptoms, the PVC burden, underlying structural heart disease, and strong suspicion of PVC-induced cardiomyopathy. The treatment, the medical treatment is again repeating that infrequent PVCs in asymptomatic patients where there is no structural heart disease, then they should be treated as benign and they need no therapy, and only therapy is reassurance and counseling of the patient. Patient have to be told these are benign PVCs and they do not cause any harm to you and they need not to be treated. If their symptoms are mild and it needs to be treated, then beta blockers or non-dihydropyridines, calcium channel blockers like verapamil or diltiazem are the first line therapy. Beta blockers are good drug, especially in patients who are having ischemic heart disease, underlying ischemic heart disease. Then beta blockers can suppress the PVCs. Rarely sotalol and flecainide can be used if the beta blockers, etc., are either they are not indicated or the first line therapy is ineffective. Then sotalol and flecainide can be used. And amiodarone is a good drug to suppress the PVCs, but it's a dangerous drug because it causes a lot of side effects. So if we have to use amiodarone, we have to use it for a short time. We cannot use it for a longer period. We have to use it in a smaller doses, and we have to keep on monitoring the patient for any thyroid dysfunction or for any lung, because Usually it can cause interstitial lung disease, or it can cause either, mostly it can cause hypothyroidism, but rarely it can cause hyperthyroidism. So we have to really look for the side effects of amiodarone. But it's a very good drug for a short-term use. Then catheter ablation is one of the method of treating PVC if the PVC burden is very high, or if there is PVC-induced cardiomyopathy. It is one of the most promising therapies. It leads to improvement of LV function and very high success rate and fewer complications. Especially if the PVCs are coming from single focus or maybe from two focus, then we can suppress. But if the PVCs are coming from multifocal, then the success rate is not that good. The success rate in unifocal or multifocal or coming from two focus, the success rate is 79 to 90% for this catheter ablation. The future direction is we have to understand the mechanism. I've told you there are a lot of theories are there for PVC-induced cardiomyopathy. We have to really understand what is the mechanism and pathogenesis of PVC-induced cardiomyopathy. We have to have better imaging techniques to look for any underlying diseases, underlying causes for this PVCs. We have to find out which are the risk predictors where the PVCs are but the burden is high and where to treat. And sometimes if we are treating PVCs, then we can prevent unnecessary ICD implantation. And because a lot of time when we are seeing a structural heart disease, especially ischemic heart disease, and we see PVCs, we try to implant ICD to suppress sudden cardiac death. But if we treat the PVC, unnecessary ICD implantation we can prevent. And similarly, sometimes when the LV dysfunction is there, we are trying to, for improving the LV dysfunction, we are implanting CRT, cardiac resynchronizing therapy. And if we suppress the PVCs, and that may cause the improvement of LV function. So that may be one of the reason for lack of response of CRT. So suppression of PVC may lead to a better response to CRT, or suppression of PVCs may improve LV function, and it may not be necessary to put a CRT. So to conclude, PVCs are a common occurrence in general population with widely variable clinical significance, because they are from asymptomatic and they can be cause for sudden cardiac death. So there is a variable clinical significance. Normally, most of the time, they carry a very good prognosis when they occur with no structural heart disease and does not require any treatment. But when present with incapacitating symptoms and or PVC-induced cardiomyopathy, appropriate therapy is indicated. And the risk factor and pathogenesis needs more understanding. And catheter ablation is a safe and effective therapeutic modality for patients with symptomatic PVCs and or depressed LV function with or without previous medical therapy. Thank you. Thank you very much.
Thank you so much, sir, for such wonderful insights upon the topic that you have shared with us. I hope that the insights shared by you would definitely help all the viewers who were here with us today at our platform in their daily clinical practices. So thank you so much for that. We have received few questions from the viewers, sir. With all your due permission, I would like to put it across to you.
Sure, sure.
The first question is, what is the role of exercise stress testing in the workup of premature ventricle contractions?
I mentioned to you that when we are doing a stress testing, there are two things. One thing, we want to see whether stress testing during the stress testing, whether the person is developing ventricular premature beats. So if on stress test, if the person is developing ventricular premature beats, then it's prognostically bad, and we have to investigate further to rule out underlying heart disease. Then we do all the investigations which I have mentioned, whether we do echocardiography to look for LV dysfunction, or to look for any valvular heart disease, etc., etc. So on stress, when the ventricular premature beats they appear, and they are prognostically bad. And if the person is having a ventricular premature beats, and if we do a stress testing, and if they are suppressed, then likely they are of benign nature, and patient may not require any therapy. So that is the role of stress testing in ventricular premature beats.
Thank you so much, sir, for answering the question. We'll move to the next question. The next question is from a viewer who wants to know which symptoms are pertinent to the management of premature ventricular contractions.
I told you basically most of the time person they complain of palpitations. So, but palpitation can occur even with a single premature beat also. So until unless person is complaining of shortness of breath or chest pain or dizziness, these are some of the incapacitating symptoms. When the PVC burden is very high, then these people may complain of shortness, chest pain, or dizziness. Or if there is a pre-syncope or syncope, or if the patient is developing preventricular PVC-induced cardiomyopathy, and that's leading to heart failure. These are some of the serious problems related to PVCs and need to be treated.
Thank you so much, sir, for answering this question. We'll move to the next question that we have received. And the question is, what is the prognosis of premature ventricle contractions in patients with underlying chronic structural heart disease or complex ectopy?
Again, I think two things are there. I would like to reiterate again once again. One thing is approximately, maybe you can say about 97-98% of the time, the ventricular premature beats are benign if there is no structural heart disease. But if there is a structural heart disease and if the PVCs are coming, we have to look for one thing, whether they are single ectopy, whether they are monofocal. Monofocal means they are coming from the same focus. When they are coming from the same focus, the ventricular premature beats, the configuration is the same in all the lead, in the same lead. So you have to identify whether they are coming from the single focus, single unifocal, or they are multifocal. Whether there are couplets, triplets, or there are short runs of VT. So when there the single ectopies are there, monofocal ectopies are there, even if there is a ventricular bigeminy is there, they are usually benign. And as more and more complex ectopies are there, the triplets are there, there are a lot of couplets or short runs of VT, they are the prognostically they become bad, and there needs the treatment needs to be there. And if the PVC burden is very high, again, the treatment has to be there.
Thank you so much, sir, for answering the question. We'll move to the next question and the last question for today's session. And the question is, which medications in the drug class antiarrhythmics are used in the treatment of premature ventricular contractions?
Again, I think I have mentioned in my talk that most of the time we start with beta blockers. As the beta blockers are contraindicated, then we can use dihydropyridine calcium channel blockers like verapamil or diltiazem to treat as initially. But if need be, then we can move further, and we can use certain other drugs which are class 1C drugs like sotalol or flecainide, which can be used to suppress PVCs. Or if the PVCs are not being suppressed, and we need to use the very powerful drug, which is a class 3 drug, which is the amiodarone, which can be used to suppress the PVCs. But the amiodarone has to be used for a short term, and we have to decrease the dose and try to decrease the dose. The maintenance dose has to be as low as 100 to 200 milligram per day, but we shall not use amiodarone for a longer period. We may use this drug for maybe for 3 months or 6 months, but during the treatment also, we have to look for the side effects of the drug. We have to monitor thyroid function, and we have to look for the pulmonary functions also to catch the side effects of the drug as early as possible. And if the patient is developing any side effects, then the drug has to be discontinued.
Thank you so much, sir. Thank you for answering the question. And thank you so much for your wonderful insight and such relevant talk about the topic that you have shared with us. We hope that the viewers must be getting the knowledge that they were here for. And I would also like to thank all the viewers for their ardent participation that they have shown throughout the session by staying tuned with us. With all your last comments, sir, we can conclude the session here for today.
So thank you very much, all the viewers, and I hope that today's talk has enriched your knowledge, and I thank IJCP, especially Ms. Batul and Ms. Nishita, for asking me to join on this platform and share the insight about the ventricular premature beats, when to treat. And at the last, once again, I tell you that ventricular premature beats, most of that time, are not to be treated, but if they need treatment, then treat them judiciously. Thank you very much.
Thank you so much, sir. Thank you for your valuable time and for your presence here at our platform. It's our pleasure to have you at our platform associated with us, sir. Thank you so
Thank you.
much.
Thank you very much.
With all your due permission, we are concluding the session here for today, sir. Until next time.
Thank you. Thank you very much.
Thank you, sir.